I'm going to talk about non-pneumatic anti-shock garment and obstetrical hemorrhage. And unlike what has been, presented earlier, we are not using it for transport, and I will tell you why. I would, at the onset, give my credit to the co-workers, Dr. Mohit, who is one of my colleagues, and Dr. Ramanpreet, who is my senior resident. I asked her to join if I hope she's in the labor room emergency. If she's able to join, she will definitely join. And of course, I would like to extend my thanks to Jeevdaya Foundation, which had given us this anti-shock garment as a gift. In fact, they had donated these to almost all the medical colleges, and it was lying unused in our labor room also for almost 2 years till I took over as head of the department, and then somehow was after my senior residents to start utilizing it, to the extent that I had to actually threaten them that if there is a maternal mortality and this garment has not been used, I'm not going to give extension to them. So that's how we initiated the use of it. To this day, when we are not only, my residents are addicted to its use, but are in fact, we are having now 2 garments because they can't think that if the first garment is under wash and there is another patient who comes and who requires it, it would be unethical not to be able to offer. So today we have 2 garments in our labor room. I'll just rush through this slide. This is a very crowded slide only to tell you how important PPH is, and I'm very sure I don't even need to read through it, except the fact that amongst, about 810 women dying of preventable causes during pregnancy and childbirth in the lower and lower medical income countries, our country happens to be one of them, where, globally, if you look at India, out of 80 deaths per day, 16 happen in India. And globally, one mother is dying of PPH every 4 minutes. And by the time this lecture ends, actually you would know that 5 mothers have died somewhere. And it is not the mothers which have died, it is 5 families which have been devastated over this lecture time only. In our country with low socioeconomic status and low resource settings, PPH is becoming one of the common indications for referrals. And unfortunately, most of these referrals become delayed. Therefore, there is a high morbidity and mortality. On the contrary, even the tertiary level hospitals, what is important is that we are handling most often the high risk population, like anemics, pre-eclamptics with eclampsia syndrome, where there is a hemoconcentration or heart disease. These are the patients who destabilize very fast, even with the small amount of blood loss. So it is not only at the periphery and during the transport that NASG is important. I think use of it in every labor room is very important, especially if handling a high load. Now, amniotic fluid embolism, we all know, is a catastrophe, and it's a volcano which can burst anywhere. It can erupt anywhere. The severity can be, never guessed, and it can kill anybody anywhere. So what is important in hemorrhagic shock is a quick diagnosis, adequate resuscitation and a medical management, and timely referral. Of course, these are the crux of the management. Just revising one slide of pathophysiology of hypovolemic shock, we all know about that you have hypovolemia, which will decrease the venous return, decrease the preload to the heart, and therefore there is a decrease in the cardiac output, which leads to hypotension, and this hypotension will lead to perfusion failure and tissue hypoxia. To the extent that if this is not rectified, there will be an organ dysfunction, and this will lead to multi-organ failure. And this is precisely where the NASG comes and plays its role. Now, what is NASG? NASG is a garment which is got a cheap, simple, lightweight neoprene Velcro device, which is very, very easy to use. Unlike what Dr. Achna was trying to say, there is no expertise required at all. It has, some components. These are the lower components. These are which are applied on the leg, both the legs, and then you have a pelvic segment and you have an aortic ball on the abdominal segment. Now, the role of this aortic ball, I'm going to stress upon when we move to the next slides. So these lower segments, when applied, will divert the blood from the non-vital organs to the vital organs. We all know that the vital organs are in the abdominal cavity. So this will temporarily stabilize the bleeding, and the aortic ball on the abdominal segment will compress upon the aorta. Since our undergraduates, we have been taught, you know, when we compress upon the aorta, it will do a lot of wonders to a hemorrhagic patient. But unfortunately, neither we ever practice it. It's all theoretical. Even when WHO keeps on recommending about it, it becomes very theoretical because we do not know whom to ask to apply the force, and when to apply, and how to apply, and how long to apply, so on and on. So these difficulties, which are the challenges to any place where there is a shortage of manpower or human resource, this garment will help us do that job for us automatically. So this is definitely, as everybody has been stating, is meant for transporting the patient to a higher tertiary center. However, in our setup, we started utilizing it for the hemorrhagic shock very much when receiving a patient in hemorrhagic shock, or when we saw that a patient is going into PPH, immediately using this in our own labor room. And then we started analyzing the impact on the hematological parameters so that we are able to convince the others scientifically that yes, garment does a change, and how it works are what I am going to show you. I will prefer to show you a video if it works for me. I have made a video which is otherwise available on the net also. Otherwise, I would request all of you to go through the WHO guidelines. WHO has made beautiful guidelines and beautiful videos to just show you how to use NASG. And in fact, these pictures are also borrowed from there. So step one is to just spread the garment on patient's bed and then transfer the patient in such a manner that the spine is parallel to this yellow line. And then, of course, when segment 1, 2, and 3 are applied from the lower limb onwards, we start with the ankle and we move upwards till up to the thigh, and then, of course, apply the pelvic garment piece, and then of course the abdominal. I'll just show you this slide. The important part is to keep the knee free between the first and second and third piece so that you can give her a lithotomy position. And this is the pelvic part, which will be placed at the pelvic bone level. So you see, this is how the garment is spread upon, and then you sequentially, these segments are tied around the ankle, calf, thigh, and leaving the knee joint free so that she can be given a lithotomy position. Then application is then made around the thigh. This is the third step, and then fourth part is the pelvic part with the lower edge at the level of the pubic bone, and the fifth segment is then applied. And then, of course, as I said, this pressure ball will come automatically over the umbilicus, and this will give the aortic pressure. Now, ideally, only one person should apply the abdominal part. The lower part can be applied by both simultaneously by 2 people to lessen the time, but the abdominal part should be preferably applied by only 1 person so that it is not over tight. And at the end of application, this is how it will look like. And what you can ask is the comfort status from the patient, whether she is normally bleeding after the application. That's the only precaution which you need to take. If the patient is feeling hot or itchy inside, you can only alter the outside temperature. You actually cannot reopen, and you should not reopen. Now, how it is going to work is, we all know that when there is a obstetrical hemorrhage, either the patient is bleeding through the vagina outside, or if there is a rupture uterus or something like that, she'll be bleeding inside the abdominal cavity. And this is the garment which has been applied. So once we apply the garment, there is a circumferential compression on the vessels of the lower limb, and there is a diversion of the blood from to the vital organs, that means the brain, heart, and kidneys, and therefore the aortic compression is going to happen, which is going to compress upon the right, internal iliac artery. So this is what it is going to do, what we expect to do through an internal iliac ligation temporarily. And this is what the ultrasound markers have shown. A lot of study has already been done to show that when aortic pressure is given, there is a decrease in the pulse pressure of the internal iliac vessels, which is what is the mode of action when we do an internal iliac ligation also. So this will eventually, what it will do is decrease the blood loss, stabilize the blood pressure, and it just takes 1 minute to apply once you become a trained. This decreases or delays the deterioration of the hemorrhagic shock, which is the most crucial step to prevent a morbidity and mortality. Now, what is the prerequisite if you are using it for transfer to the another tertiary level hospital? Would be informed consent, placing an indwelling catheter and a Eurosat to be applied. The referral slip should contain all the relevant details, and these are, of course, what is the guidelines of Lakshya also, that all the antenatal, intranatal delivery events, instrumental use or not, the time and time period of the cesarean section, indication, any blood transfusions given, any time of delivery, placental roads, means for that matter, all details should be mentioned on the referral slip. You can give the patient or start her on oxygen and with 2 IV lines, which are the prerequisites or part and parcel of the management of shock. And this patient should be transferred accompanied by a nurse or a doctor or a patient's attendant. Now, what are the advantages of NASG? The NASG is a life wrap. It's truly given the right name, life wrap. Why? Because it is a flexible garment, and therefore you can continue to offer whatever we otherwise offer to a patient of hemorrhagic shock. These can go on side by side. You can continue to give her uterine massage. You can continue to give her uterotonics. This permits lithotomy position. You can see that this is the position. That's why we kept the knee joints free. And you can do any procedure which we require to do anywhere, either at the periphery or at the tertiary levels, including the examination procedures, repairs, manual removal of placentas by compression or DNC or whatever needs to be done can be carried out. Similarly, by keeping the segment 1, 2, and 3 in situ, you can even carry out the laparotomy. Just you need to open the last 2 segments, that is the pelvic and the abdominal segment, and you can conduct the laparotomy and just give a position, a little bit of Trendelenburg's position, operate as quickly as possible because that is what is required, and then replace the garments, the 5th and 4th, 5th, 6th, which was removed after the surgery is over. Only small attentions need to be given to patients where they are obese, when they are short statures, and if there is any need for replacing the soiled NASG or when she defecates or wets it. Now, these are very well given. All these things are very well given on WHO guidelines. So therefore, I would like to save time so that I can show you a video. Now, most important thing, which probably is the removal criteria of NASG. Now, what are they? Never be in a haste to remove the NASG. You begin NASG removal only after the patient's condition is stable for at least 2 hours. What is stability? If the bleeding is less than 50 ml per hour, if the pulse is improved and it is less than 100 beats per minute, and the blood pressure is stable and more than 100 millimeters of mercury. Every institute can decide its own threshold for the stability. The hemoglobin by then, because all the things are going side by side. NASG is only a part, and which is an additional part. Otherwise, what what the other components of management of the shock are, they are simultaneously going on. So we are giving blood transfusions, we are given fluids, and whatever specific management is given. So we expect that the hemoglobin will be built up by at least 7 grams before we plan to remove the NASG. Patient is conscious and aware, and therefore we start the stepwise segment removal again in the same direction in which it was applied. What I mean, it means that you start removing from the segment 1, 2, 3 onwards. So after removal of every segment, what you need to do is wait for 15 minutes. In our institute, we follow the rule of 20. Why? Because after every 15 minutes, so now after 20 minutes, we need to check the pulse and blood pressure. If the pulse pressure is increasing beyond 20 beats per minute, or the BP falls by 20 millimeters of mercury, we need to reapply. Otherwise, if there was stability, we can go on to the second segment, remove it. After removal of the second segment, again, we need to wait, and so on and on till we are able to remove all the garments. Otherwise, if in case there is instability, we need to reapply back again those garments, and then we start looking for a cause and what further management or intervention is required, like we do it for any other case of hemorrhagic shock. So if there is a recurrent bleeding, we need to determine the source and arrest the same. Any contraindications? Barely none, except for the cardiac failure, and that is quite understandable if there is a pre-existing mitral stenosis or pulmonary edema, because once we are going to apply the lower garment segments, the blood is going to be shifted to the upper part of the body, and this will of course increase the venous return, and therefore if there is an existing mitral stenosis or pulmonary edema, then the chances of patients going into failure are increasing. Otherwise, except for abdominal evisceration and open pelvic fractures, which happens more of in the traumatic cases, not applicable to pregnant women, of course, these are otherwise contraindication. In pregnancy, if there is, there is a live fetus in cases of antepartum hemorrhage, again, this is a contraindication unless we felt that the mother's life is at risk, and of course, where we compromise the fetus and save the mother. Now, principles to be observed, I have already said, preferably the upper segments to be applied by one person so that we are not overtight, and then of course, ask the patient. Patient can be monitored as we monitor any other patient of shock, especially looking into the urine output, because we know that the diversion of blood is now improving the renal flow also. And this is one of the markers which will tell us how well the patient is doing. Airway protection and aspiration protection is the critical nursing care, which we give as we give to any other patient of hemorrhagic shock. Cleaning and storing of NASG is extremely simple. Just wash it, dip it in a disinfectant, dry it, pack it in a clear plastic bag, store it, and we store it in a visible site which is displayed prominently so that nobody misses it and it has an easy access. Now we have the use of NASG in our own hospital settings, and these are the common diagnoses where we required to use this NASG, which as you understand, the common causes of hemorrhagic shock being antepartum hemorrhage, ruptured ectopic, postpartum hemorrhage or inversion, and these are where, in fact, even after an abortion, post-abortal bleeding also we used this, and we have a data for about 25 patients after 1 year. Now we have stopped keeping the data because it has become a routine practice of use in our institute. Now the parameters which we thought we should study as our primary outcome so that we are able to convince the others how important it was the vitals we noted at admission and after 30 minutes of use of NASG. And ideally, if somebody is transporting the patient, one should mention these vitals during or just before the transport. We did it intraoperatively, preoperatively, postoperatively, and at the removal of the NASG. The parameters which are, of course, I will not go into the details of this, the vitals which are now the hemodynamic parameters to be studied are shock index, which is heart rate divided by the systolic blood pressure, mean arterial pressure, that is the formula is well given, and modified shock index. We are the first ones to have started studying the modified shock index. The normal values of which for shock index are 0.7 to 0.9 in pregnancy. They are not the same as that in the non-pregnant state, and many studies are still ongoing to see which is the accurate one shock index for pregnant women. But we did our study with 0.7 and 0.9 as the literature showed this would be the ideal one. So the time required, we studied also as a secondary parameters, the time required for issuing of the blood, the amount of blood products, the duration of use of inotropes and NASG, the kind of surgical intervention which was required after use of NASG, and the survival status and duration of hospital and ICU stays versus the old retrospective data when the NASG was not in use in institute. Now, again, I know that this is theoretical. I will not take much of the time just to tell you that these are the results which we started plotting for all the patients one by one, and I will just show you the mean changes. Now, these are the mean changes. Here you can see the shock index, mean arterial pressure, and modified shock index. And you would see immediately 30 minutes after the application of NASG. And of course, notwithstanding that resuscitative measures were going on side by side because you cannot stop them. It's a life-saving procedure. So shock index, you would see within 30 minutes was down to 0.9, a gross improvement, mean arterial pressure increasing by at least 10, and similarly the modified shock index, there was a gross improvement. And you can see these are the normal values before the NASG was removed. The time period, of course, was variable. So now these are just the graphical representation of the shock index, and you will see gross improvements of shock index in every patient. There's some patients who took some time, and then, but grossly, from admission to post-removal, you would see there was always a drastical improvement of the shock index. That means the patient was being resuscitated too well. We saw the improvement in shock index in almost 52% of the patients of PPH and in 46% of APH within the first 30 minutes. Now, these are the graphs where there is no application of NASG in APH and PPH. Believe me, we could not write a project because we thought it would be unethical even to write a project where we want to compare the use and non-use of NASG, because once you know that the patient, it is a life-saving garment, you cannot ethically not offer the same. So we never will get a control group. And so what we did was we just took out the data from 2 years back when we were not using NASG, just to see how different the data is. Now you can see here only 12% improvement and only 17% improvement in APH and PPH cases. This is what is just the graphical representation of what I am trying to state. Now, the only thing which I wanted to tell you was that there was, of course, no way to compare with whom to compare, what was the quantity of inotropes used and what is the duration of NASG, use of blood products, ICU and HU stay. But this is our observation that NASG had a great impact on the quantity and quality and duration of use of inotropes, blood and blood products, ICU and HU stay, and hospital stay. Even the kind of medical and surgical interventions like dialysis, renal dialysis because of the renal failure, castrating surgeries like cesarean hysterectomies, and could be replaced by much less drastic interventions, and eventually, therefore, we could improve the morbidity and mortality of a lot of patients whom we managed with NASG, along with the resuscitation and other managements for hemorrhagic shock in our setup. So for academic comparison is not possible, as not offering NASG to anyone would be unethical, but this is our gross observations. Now, I've already enumerated that the NASG application for requirement of inotrope was maximum for 6 hours when we used NASG, and the lowest dose of inotropes were required. Contrarily, prior to use of NASG, that means almost 2 years back, what we observed that the inotropes were often required for a longer duration and in much higher doses. The duration of ICU stay could be reduced on an average to 1 day. Without use of NASG, despite ICU prolonged stay, what we observed was that the patients more often required longer stay, as well as more morbidities were observed, and patients more often required the management for or dialysis for renal failures. So these are even the blood. We thought, the most beautiful part of it was that there was about 40 to 45 minutes of time period when the patients could be easily controlled of hemorrhagic shock, and the residents had an ample time to cross match the blood peacefully. No spin technique cross matching was done for any patients ever since we started using NASG. So we think that even the blood reactions have been less and probably prevented. So we did a retrospective comparison between the use of NASG in only 4 patients, just to show you a comparative chart of these 4. What you will see common in all these is that this is the blue line, which shows us the improvement of shock index in the patients where NASG has been used. Whereas in the orange line, this is an artifact, because zero is, there is nothing like zero. We can imagine that this orange line, this is a graphical artifact. Otherwise, you can imagine that this orange line is, always above the blue line, meaning thereby that even if with all the resuscitation in patients where NASG was not used, even if there was an improvement, the improvement was much slower, and you would see that it was always lesser than the patients where NASG was used. So we have drawn these graphs only for 4 patients in APH, post-abortal bleeding, ectopic pregnancy, and in PPH. And you would see that more acute the loss is, more improvement you can observe with the use of NASG immediately. So I would just like to conclude that NASG is a cheap, cost-effective, and reusable garment. It's easy to apply, clean, and maintain. It prevents or delays hemorrhagic shock, thus stabilizes shock, delays conversion to irreversible state of shock, decreases blood loss by about 50 to 78%, maternal mortality and morbidity by 50 to 55%, and the time gained permits proper cross matching of the blood, obviates any need for any rapid spin techniques, as well as it gives you enough time for anybody to arrange help. You may require seniors, you may require anesthetists, or you may require many things which you can peacefully carry out when the patient is going into shock and immediately reverted. Now, probably this would, that's our observation, it decreases the use of ICU stay and HDU stay. I don't, in fact, for what I remember is that we more often have required the patients to stay in the high density unit of our own labor room, very infrequently required to be sent to even ICU. But whenever they are sent to ICU also, the stay is much shortened. On no risk of overinflation and excessive pressure, because this garment is not non-inflatable, has no tubings, no pumps, valves, or gauzes. So while use of NASG is primarily being promoted for transport of hemorrhagic patients from periphery with constrained human resources and insufficient resources in developing countries, we personally have started advocating its use in every labor room, at least of a tertiary level hospital, so that our residents become our ambassadors for promoting its use anywhere and everywhere. And personally, we feel that it's not only from preventing hemorrhagic shock. I think every drop of blood which we can save in a poor country or in a developing country like ours counts. So therefore, we have been, training the medical colleges through the foundation which gave us this garment. And so far we have given about 11 trainings, including I think 4 to 5 medical colleges each settings. But I don't know how far it is being used. But I would advocate that please try to read more about it. You can contact us anytime whenever you feel that this is required.